For this segment of the class, we're going to talk about a paper that appeared in September of 2012 from Denmark called Risk of Diabetes Mellitus in Persons with and Without HIV, a Danish nationwide population-based cohort study by Lena Rasmussen and a number of colleagues. This is a study that addressed the question that we've just reviewed of the occurrence of diabetes mellitus in persons with HIV. It's a retrospective cohort study. That means it's built on data that were already collected and available, in this case, from a number of different sources, which are now being put together and being analyzed. What we'll do with this segment is, most importantly, understand how the cohort was assembled, and then look at some of the basic measures of risk for diabetes and how these were broken up, comparing people with HIV to people without HIV, and then comparing people with different characteristics among the HIV population to see what was predictive of the occurrence of diabetes mellitus. So, the structure of this study, and we'll go to the whiteboard in a minute to draw this out, involved using a group of people with HIV who had already been identified in Denmark, and they had been put together from a group of treatment centers within the country, which represented all of the possibilities for treating HIV. So it was a complete list of the HIV patients. And the work that the investigators did was to create a comparable cohort so they could look at the occurrence of diabetes in people without HIV and people with HIV and begin to draw some inferences from those. So remember that the fundamental structure of a cohort study is to take a list of people, to have a lapse of time, and the ability to observe disease events in those people. So let's talk about the data that the Danes used to put this study together. I can work at the whiteboard, so I have to take off my coat so not to get extraneous signals, and let's see what we can do. So they started with a cohort of HIV patients, which had been put together from the various clinics that were available in Denmark, and this is, remember, a complete set of these patients. And they wanted to look at the occurrence of new cases of diabetes in that population. So they used another database that's available in Denmark, which is of hospitalization and clinic data, from which they had the occurrence of diagnoses of various kinds. So they would ask for people in the HIV cohort, did they have diabetes? And if the answer was yes, they were out. So taking some data from there. And so now we had people without a diagnosis of diabetes. And they took another resource in Denmark, a prescription database, to ask were they being treated with any drug that might be used for diabetes. And they were out. Now, at the beginning of this whole process, they actually had applied another filter from Danish national registration data. Registration, we'll get better pictures of this afterwards. Registration data asking whether or not people lived in Denmark. So that went through there. So now at this point, they had a group of people who'd gone through these different filters who had HIV, who did not have a diagnosis of diabetes, did not have treatment for diabetes. And here was where what we can do in Denmark was really, really exemplary. They used the same national registration data to create a comparison cohort of people who have the same age, sex, and they were resident of Denmark at the same time. And in fact, for both of these, they restricted it to people born in Denmark. Put them through the same filters. Do they have a diagnosis of diabetes? If yes, they were out. Did they have any treatment for diabetes? If yes, they were out. And now we've got our study populations. We have a group of people with HIV and a group of controls or comparators who don't have HIV. They've got the same distribution of age, they've got the same distribution of sex, they're alive in Denmark at the same time. And now we're going to find out information about them. So let's go in another slide here, how we would use that same data, the registration data, the pharmacy data, the hospital data, to identify the outcomes. And so we have here our HIV patients and our control patients, and we use the prescription data to identify treatments for HIV and other things, and we have new diabetes. Okay, and then we use the hospital and clinic data similarly to look for the occurrence of new diabetes. And between these, we now have our outcomes. We can talk about what's called the risk, so the probability of getting diabetes in these groups. So now we'll go on to the results that they presented. The first, you'll find when you look at figure 1, a curve that looks something like this. Gently sloping up, and then there's a dotted one where it's almost the same. And this goes out to 14 years. And at the top here, that's about 5%. At 10 years time, it's about 3.5% of people have gotten diabetes. And it's exactly the same between the two groups in this population. This is called a cumulative incidence or a cumulative risk curve. The idea is that you have a population, you follow them forward, you find out with the passage of time what fraction of people develop the diabetes. And here it really wasn't different at all. Now, this is a measure of risk, but we said that things were changing very rapidly with HIV treatment. The treatments are coming in and out, the different characteristics were, time was changing, and other supportive therapies. So the risk over 10 or 14 years doesn't capture this kind of movement of risk that's happening to individuals. And in order to look at that, we need to go to a different measure of occurrence. And we use a denominator called person time. Now, to understand that, let's look, say, at this 10-year period here. So we've got a risk of around 3.5%. We could ask ourselves, all right, so this is approximately a straight line. It's not exactly. What does this correspond to in terms of an annual risk of developing the disease? And the notion of person time takes these shorter and shorter periods of observation and asks, in that little period of observation, what's the risk? Next one, what's the risk? The next one, what's the risk? The power that you get from doing that is that you can change the labels, if you will. You can change the cohort designation in those groups. So you could say on or off treatment. How is the risk changing? In early years versus later years, how is the risk changing? This just mixes together all the calendar years because it follows from the time you have HIV forward. You could ask for men or for women, for people who have different amounts of lipodystrophy, which is this problem with the fat distribution. What's the risk of diabetes? And so the second part of their study was to accumulate person time in different categories of age, weight, the occurrence of lipodystrophy, gender, calendar time and look at the annual risk in individuals within clean categories of that. So one person over his or her lifetime experience might move between different categories. You definitely move between different categories of age. You almost always move between different categories of treatment. And here, when you go to a person time measure, they're able to look at the effects over time. So let's then stop and look at the what you got with some of these person time measures. And here we're going to go to table 2 in the analysis, and we can look at the person time measures. And I'm going to just have you look at the very first figures in that. In people with HIV, overall, there were 105 new cases of diabetes, and this was in 3,500 people, but those 3,500 people had 28,105 person years of follow-up. So 28,000 individual years for these people. So this is taking everybody mushed together, and we can see that that rate's around 3.5 cases per 1,000 person years. And that's what we call an incidence rate. And not coincidentally, that's very close to the figure that we would have gotten from that graph of cumulative risk. The importance here is that we're able to break that up into different pieces, so that they're now able to look at the effect of time. For illustration right now, we'll go through other things in the questions. Let's just look at obesity. So they looked at the risk as a function of whether you were thin, medium, fat at the beginning of therapy. So if you were very skinny, the incidence was 3 cases in 1,513 person years. So that's about 2 per 1,000. If you were very heavy, BMI of greater than 30, it was 21 out of 899 person years. And that was it. So that would give you a risk of around 25 per 1,000. So a tenfold variation in risk. So what have they done? They've taken people, they've broken them up, and now they've taken this person time measure and looked at the range, and we see that there's a tenfold risk. That's the risk measured at baseline. They're also able to do the same thing with varying degrees of the lipoatrophy and different kinds of treatments. And as you'll see as we read through this, they come to conclusions about the risk of different characteristics based on a person time analysis that they couldn't have done based on this cumulative risk analysis, because here we can't allow for the fact that people are changing with time. So let's review the questions that you're going to be answering and that we're going to be discussing then in another week. All right, so first of all, I want you to go through the text and be sure that you really understand the pieces that went into the work of creating this cohort. The Danes used lots of existing data, linked them together through a common person number, it's called, to create these study populations, which were artificial, but artificial in a very good way, that they became comparable. And I'd like you to work through the exercise of doing that. With the looking at that figure 1, the one that corresponds to what we have here, looking at the cumulative incidence, I want you to work back for yourself and see what the approximate annual incidence is. And then I want you to be sure that you have a good sense of how the investigators break up the characteristics that they're going to study. And there's an interesting process here which determines whether or not you can do a cumulative risk curve where you have to look at person time. And that's by asking whether the characteristics are ones that are fixed and knowable at the beginning, in which case you can just make so many cumulative risk curves, or whether they're ones that change over time, and whether we need to go to a person time measure. Finally, we're going to ask the question of what we've learned about changes in risk from this information. And we're going to look specifically at the one of the baseline measures, which is differences in the risk of diabetes in relation to how heavy you are, so that gradient we saw from thin to fat. And I'd like you to think about whether or not that tells you anything about, to answer the question of whether getting skinny, does losing weight change your risk once you've started in the cohort? This is an important distinction that we're going to have to think about and that we'll talk about next time. Thank you.